Thank you for inviting me.
Well, hello everyone out there in SADS Facebook Live land, and thanks for joining us on this Friday, June 26th. It's really great to be with you. This is our 19th episode, and some of you have been with us from the very beginning, and I'm really excited to have a dear friend of mine, Dr. Charlie Berul from Children's National Hospital in Washington, D.C. He is Chief of Pediatric Cardiology there, a pediatric heart rhythm specialist, a device innovator, and we couldn't think of anybody better to have join us today as we focus on devices as they relate to our patients. So Charlie, thanks for joining us today.
Thank you, Mike, and thank you, SADS, for having me be part of this exciting Facebook Live. I was reminiscing when about to come on here that Mike and I have known each other for probably 25 years or something like that. In fact, when we used to go to some scientific meetings and Mike and I were the speakers, our sons would be in the back row with coloring books, and we'd take them out in Orlando or New Orleans or San Francisco, and we got to watch each other's kids grow up through these scientific sessions, and now they're all adults.
Yeah, that's a fun stroll down memory lane. And Charlie's been a very special person for the SADS Foundation. He's been on our scientific advisory board for many years now, so thanks for your role in that. And on behalf of Alice Laura, who is our CEO of the Sudden Arrhythmia Death Syndrome Foundation, thanks all of you out there for joining us, and start thinking of your questions to present to Dr. Berul and myself as it relates to devices. We're going to focus on devices, but before we do, I just want to give you a recap and a reminder. We're about day 100 of our coexistence with the SARS-CoV-2 coronavirus. COVID-19 is still here as much as we want it to be gone, and just looked it up. Worldwide, we are approaching quickly 10 million cases and coming upon 500,000 deaths from COVID-19. In the United States, 2.4 million cases, although I saw today from the Center of Disease Control that actually might be a tenfold underestimate, and 124,000 deaths. At Mayo Clinic, again, an advantage of being one of the largest medical centers in the world in a nowhere cornfield called Rochester, Minnesota, we have not yet reached 1,000 cases, and we've had only 15 deaths. But that's not been true in bigger cities like Charlie's, where just in the county for District of Columbia, they've just crossed 10,000 cases and over 500 deaths. And Charlie, we're going to focus on devices, but before we do, what is things like in DC as it relates to COVID-19 and in the children's hospital specifically? Any observations that you had?
Yeah, it's been a major change. I mean, everybody, wearing masks and all the PPE. It's been, as you said, about 3.5 months now. And Children's National has patients from Maryland and Virginia, as well as the District of Columbia. And so we're seeing a lot of patients with COVID-19. We've tested over 10,000 pediatric patients ourselves. We've had over 100 employees that have had COVID-19. And fortunately, everybody's doing well. Everybody's survived. All of our pediatric patients have survived COVID-19. Some have required some pretty major care plans, including pediatric ICU care, ECMO care. But fortunately, we've done well with those children. And we're even taking care of some young adults up to about age 30 so that we can offload that from the adult hospitals who have been swamped. One of the unique things that's in pediatrics related to COVID-19 is this new entity that is being called multi-system inflammatory syndrome in children, or MIS-C, as you know. It's had a couple other different names. It's similar to Kawasaki disease presentation. Sometimes it's been called pediatric multi-system inflammatory syndrome, but the CDC term is multi-system inflammatory syndrome in children, or MISC. And we've seen over 30 cases of it here just at Children's National, all hospitalized. So not even counting the outpatients. We've had over 30 to 35 hospitalized children with it. Again, all doing well and treated the same way we treat Kawasaki syndrome with anti-inflammatory agents and high-dose aspirin. But it's all of a sudden, we weren't seeing any of them until May. One of my colleagues actually wrote a case report thinking it was Kawasaki syndrome after COVID, but turns out that might have been one of the first recognitions of this newly recognized entity.
Yeah, I think that's really interesting. And I think, just a reminder for all of us out there, we need to stay coronavirus free for as long as we can. And in fact, it was sobering news yesterday. Yesterday was the first day that there were over 40,000 new cases. We had been tracking in the 20,000 new case range for the last months, and it just hit 40,000 cases yesterday alone. So we all need to do what works. We need to do the social distancing, everybody, physical distance, socially connected. We need to do masking in the public square. I mask, you mask, we all mask together. My wife and I were just at lunch, and we were the only ones at the restaurant with a mask on. It is not going to work if we're not doing masking in the public square. And we need to wash our hands, don't touch our faces. All these things are simple and they work. And unfortunately, we're starting to observe that people must be either fatigued or just done with it because they're not doing it. So I just encourage all of you out there, do it. It works. And the longer we stay coronavirus free, the better. New treatments are being observed. We're learning what's working, what's not working. And you don't need to stay coronavirus free because you're at greater risk. Remember, we've talked about that. Those of you with genetic heart diseases, long QT syndrome, CPVT, you're at no greater risk of COVID-19 than Charlie or me or Charlie or my children or my grandchild. That's not the reason. It's just good to stay coronavirus free for as long as we can. And Charlie, before we turn to devices, are you starting to observe that people are getting sloppy with the things that work?
Yeah, I mean, it doesn't work if you wear your mask like this, right? And we see a lot of people wearing their mask like this. And that is not the purpose of wearing a mask. And like you, I've seen people getting a little bit more lax and as the states are opening up and restaurants are opening. One of my sons works at a fitness center and he wears his mask as the trainer, but a lot of the customers say it's too hard to exercise with a mask on. So they're huffing and puffing and breathing on him in the front, and he's got a mask and goggles on. But it's scary as we relax the guidelines. And as you said, I think it's not that patients with inherited arrhythmia conditions are more susceptible or that they do worse. It's the same, but you're also not automatically safe either. Having an implantable defibrillator isn't going to protect you from coronavirus. So it's important. And there's plenty of medications that are on your list of do not take medicines, and some of those have been touted as treatments. And I think that's cooled down a little bit and not as concerning as it was a couple of months ago. But yeah, I think it's concerning.
Yeah, and you mentioned implantable cardioverter defibrillators or ICDs, and let's turn our attention to those. And most of those out there in SADS Facebook Live, what I think about ICDs, and no matter how good they get, I've said most of our patients with long QT syndrome, most with CPVT, most with Brugada syndrome, do not need and should not receive an ICD. We're not going to be talking about the overuse of ICDs. They're being tremendously overused. It drives me crazy, drives Charlie crazy. But what we are going to talk about is for our patients who need an ICD, who need a device, we're going to talk about what is the state of device technology and ICDs specifically. And Charlie, take us down memory lane, sort of the history of pacemakers and defibrillators and just the incredible advances that you've seen in your career. You've participated in those advances, but bring SADS Facebook Live kind of from back then to now, and then I'll come back and ask you a little bit what you see as the near future with device technology. But let's go down memory lane first.
Sure, we can start just briefly with pacemakers because that's got a much longer history. And as you know, the first pacemakers had to plug into the wall, and they used an extension cord to get the guy down the hallway and let him walk with his walker. And then they became implanted, and they were pretty large devices when pacemakers were first implanted, and really couldn't be used in children. And they've been around, now for over 50 years. Implantable defibrillators are the newer cousin, and were really invented in the late 1980s, and first started to be used in children in the early 1990s, which is when I first started working in this field. In fact, I put in 1994. At that point, was the world's youngest patient. She was 7 or 8 years old.
Wow.
The device was so big. I'm going to pull this off my wall. This plaque given to me by the pacemaker company. It says the world's smallest patient. And she got one and I got one. That company is now out of business. Huh. She's now a grandmother herself. It is an early grandmother. No, she's not a grandmother. She's a mother. But the mother that I took care of her is a grandmother, because she has a child now in her late 20s, doing very well. But that device was so big, when we put it in her belly, it rubbed against the bottom of her ribs when she stood up. And here's some of the old devices from the 1990s. Look how thick that is. And that's not that long ago. 1990s, yeah, it's the 20th century, but it's not that long ago. And we've come a long way. I'm trying to put them out without the manufacturer, because I try to be agnostic as to which manufacturer. This is a relatively newer device. You can see it's much thinner than the old one there.
Yeah,
right?
Yeah.
So, there's a big difference. These can fit much better cosmetically under the skin and soft tissue, under the collarbone here in the chest wall. And there's no way you could do that with the thicker devices back 20 years ago. So now children as young as 7 or so can relatively easily get an implanted defibrillator through the vein without having to do open surgery. And pacemakers have gotten much smaller too. Pacemakers are significantly smaller. I'll hold this just for comparison. That's a defibrillator. That's a pacemaker. They're backwards, so you don't see the brand names on them. But the pacemaker here is small and thin, and it's continued to evolve in history. It's been exciting to watch that over the past 25 years, and the miniaturization. Still big though.
Yeah.
And we still can't use those in infants and toddlers yet. And pretty much anyone under age 3 or 4 still has to have open chest surgery to get a pacemaker or defibrillator.
Charlie, you mentioned how they have just miniaturized, and now we can put pretty much the standard defibrillator under the collarbone in age 7, 8 years old. But every once in a while, we'll have very malignant long QT syndrome out of the gate in the baby. And, you and your team was pretty instrumental in helping us learn how to jerry-rig a device using the standard defibrillator, but hiding it in the belly and putting the leads on the outside of the heart. Tell us a little bit about your role and that innovation and that aspect of device innovation that you saw firsthand.
Yeah, it was a while ago. It was actually in 2000, and several different groups, including ours, came up with this similar concept, but none of us were smart enough to patent it. And the idea was similar to an external defibrillator, where you put the patches, on the outside of the heart. On the outside of the chest, against the chest wall, when you defibrillate someone with an external defibrillator. And we first tried it in animals and then in infants, and put this little coil just under the skin, outside the chest, outside the rib cage, and put the defibrillator that was meant to be under the clavicle, and we put it in the belly, and it worked. And we were able to then implant defibrillators in infants and small children. Now, since that time, a company that was much smarter than us decided to copyright it, and that's now called the subcutaneous ICD, and is really the same concept of what we described in the U.S., and then a Swedish group and a German group we all reported within a month of each other about 20 years ago now.
What's interesting about that baby way, if you will, the epicardial ICD, is most people kind of think in their minds, well, that's how we do it for just the babies. But we've done it in several occasions now at Mayo Clinic for some of our elite high collision athletes, where we have felt that hiding the generator in the belly and having the leads attached to the back of the heart with a very minimally invasive approach, which you guys developed as well, is strategically has been a really good way of configuring the device. And I guess that all goes into, we have several device options now, and it's really precision device therapy, not just precision medicine, but precision device therapy of what's the right device and the right device configuration for that right person for all the things that he or she wants to do. And I know you've seen the same thing in your practice, right?
Absolutely. It's got to be customized. And as you and others have talked about, sort of shared decision-making with the patient and the family, maybe involve the teacher or coach, depending on their level of elite athleticism, but certainly giving them the options that aren't just the standard, this is the only way to do it approach.
And tell us a little bit about the S-ICD. I have my own thoughts about how enthusiastic I am or I am not yet for the S-ICD, but we'll tell our community how that device works, how it's configured, and what role do you think it plays when you're trying to decide if that's the right device for your patient?
Right, that's a good question. And clearly the S-ICD isn't for everyone who needs an ICD. And right off the top, it's not for people who need pacing. It's not for people who need anti-tachycardia pacing, meaning pacing to treat a fast heart rhythm. And it's not for people who need resynchronization of the electrical system of the heart, which transvenous ICDs and pacemakers can provide. And so those three conditions sort of exclude the eligibility for an S-ICD. But if there's somebody who just needs an ICD as a just in case for a shock for defibrillation, then it's an option. It's still bigger, significantly bigger, even though the second version is smaller than the original. It's still bigger and bulkier than the defibrillators that are used for transvenous defibrillation. But they've gotten better. They go usually under the left underarm here on the side rather than in the front. And so that's got pluses and minuses depending on where you want that bump of your device to be. And it's a little bit more surgery to put the S-ICD in under the muscle, the pectoralis muscle or lateral muscle there, compared to putting it up here. So there's a little bit more soreness for the first week or so after having the device. The big advantage, though, is there's nothing in or on the heart. Mm-hmm. And so if and when you have to take it out, it's safer because you're not extracting a lead that's stuck in the heart. And you don't have to worry about if there's an infection, you don't have to worry about the infection going into the bloodstream as much. So those are the advantages of the device.
Yeah, I mean, I think in principle, to me, the device is incredibly exciting, the device that does not touch the heart. And I like that. I like for some of our hypertrophic cardiomyopathy, there was obvious concern as would it work for a thick heart? And the answer looks to be, yes, it does. But I don't quite like it for my long QT patients yet. Even the new generation and the new software, I just am still concerned that with the dynamic T waves that we see in our long QT patients, that Brugada, yeah, that will get more shocks inappropriately. And we've unfortunately have had to remove more S-ICDs because of inappropriate shocks for T-wave oversensing and problems like that. Now, granted, that was with the first generation, and maybe we're getting better and better with the newer software technology. Well, do you think we're there where we should be thinking about the device for long QT and Brugada, or let's wait and see for generation number 3? What's your own thought right
Yeah,
now.
I just put one in, a patient with long QT 2 days ago, and he had a cardiac arrest, so he met indications, not one of these overuse ones. And I talked to the family about it, and they might be on this, on listening in because they're active in SADS. I talked to them about it and presented the options, and together we decided that a transvenous system is probably better for him, weighing the advantages and disadvantages. And for most of my patients, I do lean more towards transvenous ICDs because of those concerns of T-wave oversensing, the time it takes to detect, so that the time it takes between getting the arrhythmia and the shock is longer with the S-ICD, which may or may not be important to some people. But the inability to pace and anti-tachycardia pace are, I think, big disadvantages.
Yeah. You know, we're starting to see some questions come in, and Courtney, I see yours. We'll see if we can get to it and some of the others. But before we do, Charlie, if you had to put out the crystal ball for what innovations are coming around the corner, or what ones that you want to see come around the corner for our patients, what do you think we're in for in the next 5 to 10 years for device advancements as you see it?
Yeah, I think I'm hoping, and some of it I have my own bias because of my own research in device miniaturization, but that's my personal holy grail is miniaturized devices and customized devices for children in particular. I think the reliability of devices is quite good now. The lead survival is better than it used to be. We haven't had as many significant recalls for potential malfunction, so that's all reassuring. But the size of the devices hasn't gotten much smaller. The device longevity hasn't gotten that much better. They still only last 5 to 10 years. So, you know, having a small device that lasts longer is better. You could always argue that, you know, they're computer-based, so in 10 years you're going to want a new computer anyway. But I'm gonna just show you some of the things we're working on here.
Yeah, please do.
This is a pacemaker, complete pacemaker, and it goes through a port. It's this size. Let's see if I can get it to the. So you can see that port.
Yeah.
The port goes like that, right through what's called the subxiphoid, right under the ribs, and opens like that to hold it in place. And that port allows you to place a lead with a camera next to it, a scope, so that you can put the lead into the pericardial space. And this lead, this is actually what we call a leadlet because it's so short, has a leadless pacemaker on the end of it. This is not yet ready for use yet. We've used it only in animals and have reported it at national meetings. That's why I can show it. But it's not FDA approved. It's not ready for use in children. That's our goal in my own lab, is to be able to put leads into the pericardial space for pacing and defibrillation without having to open the chest. And I think the less invasive or more miniaturized you get, the better it's going to be, not only for the smallest of patients, but for adults who would benefit as well from having less invasive procedures.
And what do you think about, you mentioned how the generator battery, we're sort of at a battery capacitance where we need a breakthrough function to get longevity of the battery past 10 years, 12 years, 14 years. People often ask, will we have rechargeable batteries? Will the muscle itself or the body itself be able to recharge the generator? Do you see that happening? What's your thought on, is that sci-fi or is that reality in a few years?
I don't know about a few years, but I think it's reality. I think it's exciting, whether it's charged by muscle or cellular chemistry or solar power. You wear a hat with solar cells on it. But I think it is. Biological pacing has been around in the research world for 20 some years to inject cells, stem cells, and make them pace. The issue is how long will they survive, and how can you rate modulate them so that they don't pace too fast. But I think we will see that in our lifetime, in our careers. And hopefully we'll see that within the next decade, some form of biological pacing.
And do you think we'll see the sort of the near future? I know there's been a report of using the leadless pacemaker in a child. I think that was done in Barcelona, Spain, by my dear friend Georgia, who we had on last week, Georgia Brugada. But
Yeah.
do you see that happening in pediatrics? I mean, a leadless atrial pacemaker, a leadless ventricular pacemaker. Where do you see leadless technology for getting it small enough to be in a kid?
Yeah, we've done a couple. My partner, Libby Sherwin, has put in a couple in 8-year-olds, about 30 kilos, 35 kilos. That's about the smallest that we're comfortable with. And again, in very select situations. But the biggest concern is once you put it in, there's no guarantee you're going to be able to get them out. And so when they need their next pacemaker in 5 to 10 years, maybe 12 years, that they're still young. Maybe they'll get them to be adult size, but by that point, the leadless pacemakers will be so encased in natural fibrous tissue that's unlikely to be able to be removed, and you just have to abandon it. And you don't want to have 2 or 3 or 4 in a ventricle. It's going to take up too much space. So I think that they're not quite ready at the size they are now. Even though they're small, they're still big for leaving them as scrap metal in the heart.
Yeah, so sounds a little right
in the epicardial space. Then you don't have to worry as much about leaving them there.
Well, let's turn our attention, Charlie, with the minutes that we have left, with some of our questions, and I'm going to give you this one from Michelle. Hi, Michelle. It's great to see you and your son. His device is one of those epicardial ICD systems that we mentioned, and she's wondering whether you have heard of any instances of COVID-19 patients with defibrillators develop myocarditis, and is he at more risk of developing myocarditis if he gets coronavirus infection because he has an ICD of basically any configuration?
Right. I think that we've certainly seen myocarditis or myocardial dysfunction with COVID-19 in children, but fortunately, having an inherent condition like an arrhythmia or a device, an ICD or pacemaker, doesn't make you more susceptible either to getting coronavirus or to having a worse outcome from what we and others have seen. We've had several kids with heart disease that have gotten coronavirus, but they do just as well as other children. And most of the myocardial dysfunction or myocarditis that they get goes away pretty promptly, fortunately.
Yeah. And I think, Michelle, it's encouraging. I follow 2,000 patients with genetic heart disease in our Windland Smith Rice Genetic Heart Rhythm Clinic. And as you know, Michelle, of those 2,000, we're now at 3. We have 3 of those patients who have COVID-19. About 20% of those patients have defibrillators of the 2,000. And so we're not seeing any increase at all. And I think, and I've not heard any colleague in any part of the world see any differential increase in those with long QT with or without defibrillators. And so it's a great question, but I really think we really don't need to worry about it, which is good.
No more than anybody else.
No more than anybody else. But Rich is asking, and I think this is a great one for us, Charlie, is to what kind of things do you talk to your future ICD patient recipient as to what to expect? What are some of the do's and don'ts? And let's do those first. What to expect, some do's and don'ts that you instruct them, and then we're going to come back to how do we deal with the PTSD that some of our ICD patients are suffering from. But we'll come back to that one. How about the what to expect and the do's and don'ts that you tell your patients?
Well, I think our nurses do the brunt of this and have a lot of the face time with the patients and their families as to the what to expect issue, and they do a great job with it. And every physician, implanting physician and follow-up physician is a little bit different in how lenient they are. And I usually let people do as much as they want to do within reason. Certainly the first month after implant, we try to have them avoid doing exercise or doing things with the arm it's implanted in so that they don't have a accidental lead dislodgement. Although those are unlikely. Somebody I implanted a couple weeks ago, the mom has emailed us 3 times about him hanging from a rope swing. One of the times was the first week after implant in a 7-year-old. And, he does this remote monitoring and everything's fine. So we worry about it, but in practice, it's less likely to happen than we worry about. But still, not advising that you go out and hang from a rope swing in the first week after implant. But
right.
So we try to avoid, hanging from that arm, doing exercise for the first month. But after the first month, when the lead is in place and the incision's healed, I allow my patients to do as much as they want. Some of that's based on some of the work that you've done, Mike, in terms of the safety of sports for people with inherited arrhythmias or devices. Some of the work that Rachel Lampert in a multi-center group has done looking at the sports registry and showing that even when it's not recommended by the guidelines, many people are still participating and do pretty well. And that even though some people have gotten shocked during or after sports, they still do pretty well. And so again, it's that whole shared decision making of understanding that there might be a little bit more risk, but there's also risk of being a couch potato and not doing sports, and the psychological aspects of being restricted from activities, the physical aspects of not doing aerobic exercise. So there's a real balance, and I'm pretty liberal in allowing people to do as much as they want to do.
Yeah, and I think what's really neat is I saw a triple sport athlete yesterday. Great kid. I think he's probably bound for NFL and baseball. He's going to probably be the next Deion Sanders, or at least I've encouraged him that he can do it. But he has a really cool. He has the S-ICD, and he found this protective wear. His mom did. It's HART protective shirt, and this is from Dick's Sporting Goods. I have no stock in Dick's. That it was actually designed for the commotio cordis issue of the baseball hockey puck, but it just covers the SID perfectly. And so that's available as another piece of protective wear. And I think those ICD families out there, there's another company that we should point patients to, Vital Beats. Vital, Vital Beats. I think it must be a European company because the prices of the shirts are in euros. And it also has some really impressive protective wear to cover. Do you encourage the athletes of yours with devices to actually do some covering or don't bother with it?
I do. If they're playing hardball contact sports, I do advise some protective cover. Now we can have them custom make it if they don't want to pay the money for a heart guard, which is kind of funny. It's the same name as the pill we give our dog to prevent heart guard. But you can just take a cheap knee pad that you get for rollerblading and have mom or dad sew it in the inside of the shirt at the space, and then you wear that shirt under your jersey or under what you'd wear for your uniform, and that provides a knee pad provides a lot of protection as well, and it's cheap if you know how to sew.
It's interesting you said you use the knee pad, because I had always give the illustration of the jock cup. But that's an image that people just don't quite feel like they want a cup used for other purposes to cover the device, but it actually fits quite well. And that can
use a new one, not a used one.
Yeah, use a new one. That is the word of the day. The advice of the day from the great Dr. Charlie Berul is use a new cup for your ICD protection. Well, there have been some great, I'm going to take one more for us and then leave you with some final thoughts. And let's see. Let's end with this one. A great question. Your patient or this patient has long QT and a defibrillator. Can I run a marathon?
Oh, that's a great one to ask. So I have a patient who a long time ago, and I told him no. He has long QT and an ICD, and I told him he should not run in the Boston Marathon. So he then emails me a copy of the Boston Globe with his picture on it, and the little quote that's in the bigger font says, "Dr. Berul told me not to run, and here I am finishing." So it's a cute picture. He did fine. We had to turn up his upper rate detect limit so that it wouldn't think he was having arrhythmia when his heart rate got up to 200 or whatever, because he was running in the marathon. But he did great. He stopped his beta blocker for it. So all the things you don't want to hear, but he did, and he did fine. Again, I would advise that if you're going to run the marathon, stay on your beta blocker and talk to your doctor before doing that.
Well, Charlie, thank you. Like the previous 18 SADS Facebook Live sessions, this 19th one has gone by really fast. It's been really special. It's been great to have you. We've done a lot of life and a lot of SADS related activities, shared a lot of patients together over these last 25 years, and you're one of the real guys in our field, and I've always admired you, respected you, looked up to you, and so I appreciate you, Charlie. And any final thoughts you want to share with our SADS Facebook community before or until we can get you back on again?
Well, I see all the questions, and I wish we could have gotten to more of them, but I'm grateful to you and to SADS for having me on, and for everybody for their interest in this topic.
And with that, we do, both of us, encourage you all, stay well, and like we say at SADS Foundation, live and thrive despite your diagnosis, live and thrive despite coronavirus, #refuse to fear, be anxious for nothing. We're going to get through this together, but together we have got to do a better job of masking in the public square, staying apart physically when we can, be careful at gas stations, at grocery stores, places of common contact, and just stay well. We'll keep doing this on Fridays for as long as you out there want us to, and you'll watch my granddaughter grow up. She turns 5 months old in 2 days, and this is, let me see if I can, this was Father's Day last Sunday. So Charlie, happy belated Father's Day to you. But that was Jaden last week. I don't get to see her this weekend. She's at the other grandparents' home this weekend.
That's fair.
So again, Charlie, thank you. Those out to you, SADS Facebook land, thanks. And on behalf of Alice Laura, our CEO, she thanks you for joining us. And if you are benefiting from this, either come onto the website, www.sads.org, or you can find us at stopsads.org. In the top right corner is a donate online button. And if you're not able to do that, tell a friend of yours how much you have benefited from the SADS Foundation, and maybe they would like to give philanthropically to the SADS Foundation. Until next Friday, take care, everyone. Thanks, Charlie. And wear your mask.